do it, but somebody from your office should be involved, because I think that is really important. Especially if you're a site that doesn't usually have a lot of students, you really want to make sure that staff are involved and they feel invested in the students' education too, because they will end up really showing your students the way many times, helping them through those logistical issues. And then you're also going to want to involve the patients in this effort too, particularly if you're not usually a site that has learners in it. One trick is to have the student provide a picture, and then we create little certificates for them that and some fairly cheap frames that the physician's office can hang in their walls, that says, we are proud to welcome student X with their picture. They are part of this national program called the NMF PCLP. Of course, you spell it out, and they are learning to take care of patients. We appreciate your participation in their education. It looks nice. It's something you can put in your waiting room or your vitals room, and that way the patients are oriented to, oh, okay, I may be seeing this student here. If you have special practice requirements or special things that are going on in your practice, say the student's assigned you on Thursdays. Thursday is always endocrinology day, or it's minor surgery day, or whatever it is for you. Let them know that in advance. That way they can get a little heads up and be ready to go. And I would certainly advocate just using email to communicate, providing contact phone numbers in case something goes wrong, they get lost, etc. Texting works too. And if there's trouble in communicating with your student, one thing I've definitely learned is lean on the experience of Dr. Jones and everybody at the NMF PCLP, because they really understand things that have worked well in the past and things that haven't. If you feel like things are going awry, put your hand up early and they can assist you. This particular experience over the summer is very well suited to student-created goals and objectives. We want students, for many of these students, they're not in their clinical years yet, in the heart of their clinical training. They've had some clinical experience, but it's fairly limited. So we don't want to jump them up to really being independent practitioners and seeing their patients. We need to stick to those proximal zones of knowledge. We need to make a jump from doing one thing. I can take a history with some discretion as to the types of questions I ask and make it somewhat focused, and then do a somewhat focused physical exam. You can't take that substrate, that primary level of where they are now, and then jump them right to what's a broad differential diagnosis and an actual actionable plan of care. So you want to keep them in those proximal zones of knowledge. So yeah, I find it very helpful to ask them where they are, and this is again something that's best done before they show up in clinic. It can also be done something that's accomplished within the first week, but have them develop some goals for themselves, and then they have to monitor their own progress. That makes it more active for them. And I like the idea of always of asynchronous communication, because in the clinical environment, I sometimes have time to sit down and talk to the student and reflect on ththings, but then 5 more patients come in and that all gets lost in the wash. And that's why I like email as well, because it provides a record. I can go back and look, especially if I'm working with multiple students at once and I have 4 in our longitudinal clerkship that work with me on Wednesday mornings. I can remember exactly what was said and whose goals were whose. More beyond setting goals, the student should offer a pathway. This should make your life a lot easier. You can certainly comment on and edit their pathway, but they should be the ones who actually develop the methodology for completing the goals. And one thing that works for some is just creating a learning contract, which is a formal application of what I just described, creating these goals, putting them through the preceptor lens, discussing the methodology, and then sign and date it if you want to be formal about it. I think for something like for this experience, for the primary care leadership program, I've been very happy having students set the goals. I haven't been so formal as I required it in writing, but that can be helpful because it does make you revisit. It gives you a framework for giving feedback certainly down the line. So in terms of beginning clinical encounters with students, active learning is always preferred. If they are many of them have shadowing experiences, and shadowing experiences are only so valuable. it can be helpful to orient the student. So, yeah, particularly to your style. Everybody's style in seeing patients is quite different. Practices are quite different. But you want to get, I would really encourage you to try to get your students seeing patients independently without you present, at least doing that initial intake sooner rather than later. We are looking for depth here and not breadth. So for my patient sessions, which usually average about 12 per half day, I much prefer my patients seeing my students seeing 2 patients per day versus 12. 2 is really where they're at, and so we're very happy with sticking with that. I do want them to take a deeper dive into that case, though, if possible. I always give them a specific goal going into the patient encounter. Most of my patients, I'm sure like yours, multiple chronic illnesses, several acute complaints, very easy to get lost for the students. So I provide some examples of specific things, just looking at the electronic record report, or past documentation, the note on the door, whatever you have in your office, giving them something specific to do, because you're going to want to come out of each patient encounter with 1 to 2 goals for learning, and that's really about all you can probably squeeze out of a lot of these encounters in terms of a formal curriculum. The assessment of the lungs, rechecking blood pressure, and looking at how the patient's doing with management of blood pressure. Watching an example of you performing motivational interviewing. So limiting the encounter, giving them something specific to do with a limited number of encounters is a nice setup for success. When you're, so I've actually had the students, we just had our first year students start with us, and geez, that was what, 3 months ago now. And so for the first day, I had them shadow me. One thing I can say pretty certainly over time is that shadowing students take about as long as students who get to see patients independently. And it's because I have to, why? It's because I have to explain so many things to the students who shadow me, and so I feel like I spend extra time with them afterwards answering questions. The students who go in and see patients before I go see the patient with the student, they don't have, especially because they're greener, they're MS1s or MS2s, they don't know all the questions to ask, so sometimes they turn around really quickly. But I know for a fact, and there's good learning theory behind this, that the chance for them to go out and at least attempt those limited goals and do so, and then get feedback on it immediately, and then go in and see it done in a different way when I'm performing this, or I guess rephrasing or clearing things up that they left open, is really valuable for them, and that's something that they can draw on later that changes their own practice style. After they see the patient, I have them present just like they would as MS3. I don't expect them to be able to get very far in terms of assessment and plan, but I make them go through everything. If nothing else, they learn the organization of that subjective, objective, and assessment and plan structure for seeing patients and doing notes. I'll ask a few probing questions at that point. I'll give them very brief feedback. I don't have time for long feedback on what they've done, but then I'll definitely include a discussion of plan of care. Very importantly, they want to know why. Why did you choose this particular drug? Why are you ordering that particular test? So it's actually more important than giving them feedback on their work is when you go through the assessment plan, explaining why. Students get very dissatisfied as they feel like they're just their plans get blown up, but they never realize the link as to why why you did what you did. Keep your teaching points limited, and if the students have any, I encourage them to take notes, because going back and revisiting these cases and those 1 to 3 learning points is a really popular or really powerful tool. And then I always tell our preceptors that you're not trying to create perfect clinicians here. The goal of our longitudinal clerkship is really, we have a couple more formal goals, but at the end of the day, a simplified view is we're really trying to create better third-year students. And during the third year, that's where their differential diagnoses should bloom, and they should really get more comfortable in synthesizing history and physical and ancillary data into diagnoses. And in the 4th year is really where the plan hits home. Now, I want them to be working on the subjective, objective, assessment plan throughout their medical training, but I know that it takes experience, and so this time, I think it's really important to understand that they don't need to have those perfect assessment plans yet. Encourage them to do so they can stay active and try to own the case, which I think is always a great approach for budding clinicians. But don't expect too much on that end for the assessment plan. Feedback, it's great to provide feedback. I try to do so at the end of the day, briefly with my students, and you will be giving there's more formal instruments that the program will be giving you for providing feedback to your students. Try to make it specific. When you ask that patient about her cough, and that was great, you took a great cough history, but then you forgot to do the lung exam. So, if the patient has a cough, lung exam should probably be included as part of your physical examination. It's specific, it's actionable, it sets limited goals. I'm very torn on the idea of using the praise sandwich. It's actually fallen out of favor, but I've gotten so used to providing, you did this really well, you should work on this, but you did that really well too, good job, that it's like hard for me to stop. It's got a reflexive circuit now in my brain, and I can't stop giving people praise sandwiches no matter where I go. So that's like everybody from like my medical student to the mechanic to whoever. So it's something that if you're in the same boat as me, maybe we should form some kind of support group for sandwich feedback. But just so you know, now the new movement is towards just providing like straight, honest feedback, and don't feel like you have to support them or give them any touchy-feely goodness about what you have to say. You can be very direct. All right. Mentoring, these students need guidance, and so we talked at the very beginning about the goals of this program and how it's really about creating clinicians who will stay with and care for those underserved communities over time, become advocates. And this is a great opportunity to get them while they're early in their training. Listen to them. The best mentors spend much more time listening than they do promulgating certain their point of view or their advice. And because the mentee needs, and particularly in working with students from underrepresented backgrounds, I'm sure a lot of you have experience, they can be quite different. And so it's really important to go where the students are living. And I have a really hard time doing so in the middle of my clinic practice day. I just can't do it. So that's why meeting beforehand or meeting afterwards with coffee or lunch, they go a long way. And as I mentioned, I think this program is really built for mentoring. It's part of its vision, and it's got a structure about it that I think allows for this as well. How do you manage your time? That is always the question, and one of the biggest challenges, certainly, every day I see patients. First, so I've got a few tricks, and I've already described these. First, make sure the logistics are set before the student arrives, because if they're scrambling for parking and they can't find your place, and you're taking multiple phone calls trying to orient them on the fly, that's not going to work. So set expectations and try to do so before they even set foot in the clinic. Limiting the number of patients, again, I think particularly for early medical students, going for depth rather than breadth is very, very important. Limiting the goals to encounter. I don't really believe in setting a time limit on presentations, especially for junior students. They don't present very long because they don't have those broad differential diagnoses. They're not going to be going through lots of clinical reasoning in front of you. Now, if they do and wander off track, then you can certainly give them some feedback and tell them, you want to keep it shorter and keep it more focused. But I wouldn't limit them on their time in presentations, because that's really where you get to see how their clinical thinking is evolving over the month with you. Focus on selecting teaching points. Obviously, I'm advocating here for a limited number of patient encounters. It has to be the right patient. The patient who's running late and needs to, catch a plane in 15 minutes or, go back to work right away, or who's just always negative, gruff, pessimistic, mistreats your staff, for example. Don't send the student in with that patient. You're setting yourself up for, or setting the student up for disaster. The patient who's got more time, who's a little kinder. I can tell you a lot of patients, one of the things that most surprise our students is how open patients are to seeing them and how much they seem to enjoy, and I get this feedback from patients too, how much they enjoy being part of students' education. They really do get a kick out of seeing this next generation and working with them. They get a sense that they're involved with the process too. And then you can also use the student to become, there's a quid pro quo here. You're providing a great educational environment. You're giving your time to the student. A student can give something back too, and that's really a nice curriculum for the rest of their careers. You always have to find a niche in your practice, whether that's that being that you're the one who does procedures, or you're the one who's really interested in kids care, or whatever it may be. I think that clinicians spend their lives trying to find the particular niche in their practice. So for your students, for my students, like one of their niches is rechecking blood pressures. It's a little bit routine, and it's not certainly all they do, but if they see a patient with a blood pressure by machine of 168/92, just like I will do if it's my patient, I expect them to recheck the blood pressure. That's a service to me that I don't need to go and necessarily do that after they see the patient. Maybe it's doing depression screening. Maybe it's following up on vaccine coverage. There's lots of things that they can do within your practice that will have value, and I think when they feel like they have value to your practice, they feel more confident and they're more able to grow as clinicians, which is the point of the program. One other idea I had for time management, and this specifically has to do with me working with a cumbersome EMR, is the idea of stations. And so I take, as I said, 4 students per half day in my practice. These are junior students, MS1s and 2s. And I believe in this model so much that I put it under a stress test last summer, and I had up to 9 students in my practice at once. And it wasn't fun for those half days to have that many students with me. It was actually physically challenging because we'd trip over each other. But the station model did work. And so the idea is you keep them engaged in active learning. All that time that I'm spending on the computer doing orders, doing prescriptions, writing notes, dictating, etc., they're not just staring at my back. If I feel like they're just kind of watching me on the computer, I feel like I've failed. So I really try to get them engaged, and it works well with pairing students. So if you happen to have 2 students with you, this is outstanding. I actually just treat them like a unit. So, Jennifer and Greg, you're together today. Bill and Alejandro, you're paired today. So they really do function as a unit. And the stations I like to use are patient care. That's obvious. They go and see patients. They kibitz about what they find, and then they go present to me, and then we go see the patient together. Note writing. I have the students write 1 note per day, and because writing good notes is getting to be a bit of a lost art, it's difficult to do in medical education. There's some schools that really turned away from it, but it's still critically important for students to learn how to write good notes. Self-directed learning or report. Student goes in, sees the patient with cough, doesn't understand what the differential for chronic cough is. I will sometimes, especially if I see that there's 4 patients coming in to see me right now and it's 11 o'clock and I'm supposed to be done with clinic at 12:15, I'll tell them, maybe this is something you should look up, and just spend 15 to 30 minutes using a credible source, not just Google, not up to date or anything where it's easy, where there's spitting back the information, but try to find a nice systematic review or some kind of, or even original research to look and support their clinical question. I think that could be a valuable thing, and they tend not to forget those. And then I make sure that they keep those and revisit them later so that it sinks in a little bit. And then the last one is something that's really special because the students really love this one, I think, more than anything else, is going back and spending time with that patient who just can't quit smoking, who's obese and seems to have tried every diet but is not losing any weight whatsoever. Practicing a little bit of limited skills with motivational interviewing, but just getting to know them a little bit, I find this really helpful because the students have that time while I'm doing the orders and the notes and all that other stuff that we have to do but we don't necessarily love to do. They actually provide me a lot of information on my patients, things that I've missed in my clinical encounters, And so I've used them for that purpose, and the students love it because they feel like, one, they contribute, two, they get to know patients at a deeper level, which is the whole point. All right. And with that, you should be unmuted. So this is our this is the class. They're all doing the zot zot. We are the anteaters, and so they're making small anteaters with their fingers and hands. And yeah, this is our last reflection session for MS1. So I really appreciate the chance to speak with you. I certainly look forward to hearing your questions and ideas. And so let's open it up.
Great. Sorry, just 1 second. I'm unmuting everyone, and it's making me do it very slowly. But I think that should be everyone. You should be able to contribute your comments or questions or start the conversation. So take it away, attendees.
So I know it's a little late on the East Coast, but yeah, any practice, anything that wasn't clear through there, do you think this is even possible with your practice? Because I try to make it certainly it caters to different practices in our longitudinal clerkship. They're almost all primary care, but certainly we see a pretty wide variety of styles and locations all over Southern California. There's a minimum number that are actually UCI practices, so they're part of our UCI health system. Most of them are community-based, and so it's been a challenge. But I think that this model is probably the one that can fit best across different institutions, with modifications, obviously, for your locality.
Hello, can you guys hear me?
Please,
yeah.
Go ahead.
Okay, sorry. My name's Carl. I'm a family doctor in Chicago. This is my first year with PCLP, and actually it'll be my first time actually getting into academic medicine. I'll be joining Rush's family medicine program where I'll have students. So it was really good to hear you speak, Dr. Vega, because right now all I do is see patients. So I actually don't have students with me right now, but starting in September I will. So just kind of hearing the different strategies, I mean, I feel like they all would be pretty feasible. I kind of like the part where you're talking about breaking the students into teams and actually, giving them duties to kind of make them feel like they're a part of the practice and the goings on there, so they don't feel like they're just sitting around. So I really appreciated it.
No, thanks, Carl. And yeah, you're right. And the thing we found, which I thought was going to be true and turned out to be pretty accurate based on the feedback from our students, was that the students appreciated being in pairs because there's just peer-to-peer education is really important. So it gives them the opportunity to do that. And then there's also a moral support, particularly for students who don't have all the clinical experience, so they can feel more confident in filling in each other's gaps when they're doing that history of the patient with cough. I used that example a few times when somebody remembers to ask about dyspnea and the other person remembers to ask about smoking history. It can be really powerful. It tends to make it stick a little bit better for them.
Gotcha. And I remember when I was a resident, sometimes we would have students in, and I kind of would try to have them come with every single patient, and that it was kind of cool to hear you say that, you can pick just a couple for them to really get, I guess, more involved with. So that was very liberating to hear. I was like, I didn't know we had a choice to pick just a couple.
Yeah, for our third and fourth years, I really want them to own the case, and that means that I don't mind if they spend a little extra time with them. And frankly, it's selfish too, because that way I can go through the rest of my schedule a little bit more quickly.
Yeah.
Because if they saw every patient, we would be there till 3 a.m. So that's just not a good model.
Yeah.
For most practices.
Yeah, absolutely. What do you have the students spend time with other people in your clinic, like a nurse or an MA or case managers too?
Yeah, that's something that they do. We have a community-based elective, so there's students who can do that. I don't know if that's necessarily going to be the best spend for a limited program. During the longitudinal clerkship, they actually have to do a project, and in a lot of those cases, they're working with different staff. Everybody in the office might be involved, and so that's the way we involve the rest of the team. But for this experience, there may just be, I'm not actually, I'm an advisor or mentor in this role, but I haven't done the clinical setting in years. But I don't think there's like that many sessions. It's about half the time they're going to be spending in their projects. So it's a fairly limited time that they can actually spend with clinicians. You may want to think about to give them something meaningful. If you only have 15 sessions to work with, maybe you want them mostly with a clinician. That said, if you're doing something really cool, like sometimes the students really love working with our dentist, for example. They might really love spending a little time in case management if they have an affinity for that. And I don't know if there's a lot of program rules around that, but I think that some limited experience, if it's extraordinary, could be great. But I wouldn't try to, from the get-go, try to spread them around, because I think that otherwise, they get a little too much of a survey approach, and they don't get to sink as much into the depth of your practice, and then secondarily, you as a mentor.
Gotcha.
I have a quick note too. Because this program is it is site-based, and so the site partners really kind of structure what how the program is run at their site. So in terms of the clinical schedule and the time that scholars are working on their projects and all of that, and that's largely determined by the site. But I think there have been some really great examples in cities where the faculty advisor, they're not directly in charge of the scholars' clinical component, but they're advising on the project and providing other professional guidance. But there have been some really great examples where the faculty advisor will invite the scholar to your own clinic for a day or an afternoon, and obviously working with the site to get approval in terms of scheduling. But then that gives the scholar an opportunity to see a different practice, and to see you in your elements. How you do things, and that can be a really enriching experience for them too, if you have the time while during the program, and if it works with the scheduling with the site.
Okay, that's a great idea. Dr. Vega, have you ever had to deal with a difficult student, like a student that seemed like disinterested in primary care, or just was, I don't know, rude to patients or anything strange like that?
Never. That's never happened. No, no. Look at the picture. Engaged they are. No, you'll see, and especially with junior students, I think one of the things that there's a naivete and they don't know what they don't know.
Okay.
So I think sometimes you have to point out issues around professionalism, issues around, even things like dress code and again, I think it's more challenging. It's if you have my uncle's a physician, my mom's a physician, etc. Then it's those students don't necessarily need quite as much help because they grew up in that culture. For many of our, first in their families to go to college. Students that they come from a different background, and they might need a little bit of coaching, and so there's some specific and actionable items that you can provide feedback on now. Certainly recognizing and respecting where they're coming from, but just teaching them this is how it's usually done in medicine, and you may want to think about this as how I usually frame it. You could be doing them a tremendous service because if they learn it now, then it's going to be more second nature than when they hit that third year, and they're generally going to be immersed in this clinical environment, this culture of medicine. So yeah, those are the things I see. It's not so much that they're mindfully egregious. Many times it's just omissions because they just didn't know, and so it's perfectly fine to get feedback there. And that's another area. Reach out to the mentor, and particularly if it's, I think, something that's really concerning, because you see students who who are depressed, who are dealing with terrible, stressful situations. I'm sure the program would want to know if you have conversations that indicate there's really something, more deeper underlying some problematic behavior, because often there is. Yeah, that's something you want to share.
Gotcha. Okay.
Yeah, I can share that in this program a few years ago, I had 2 students who couldn't be more. They were so different with regards to their approach to the experience and their level of professionalism.
Okay.
It was, and so what I did was I ended up telling the student who was really in a different place, and she was advanced too. She was going into her 4th year.
Okay.
And hey, work not the other students hearing from me, but talk, just kind of mention how you organize things, how you keep your day straight, how you manage deadlines. I think that because that peer-to-peer education could be really valuable, and so we would. I find my best work as an advisor and mentor in this program is over pizza and beer. So that's where we found that bond. And if you have the right students open to it, it was remarkable, because it was a lot more reinforcing coming from a peer than from me, I feel.
Gotcha. Okay. Yeah. Again, I appreciate this. Because I don't have any students yet, and I was a little anxious, but this has been really, really helpful to listen to.
Well, you're gonna be. I can tell you right now, you're gonna be great at it, because you are interested and engaged, and that's so much of the battle when we're recruiting positions for our longitudinal clerkship. I'll start with that, and if anything, and I'll make it work if we've got that.
Okay. Cool.
And is there anybody else with any comments or questions?
Oh, I was just going to say, this is Joy again, that the scholars really, really value the mentoring from the faculty advisors. I mean, they have a number of different people that they work with at the sites, and different clinicians and staff and leadership. But the relationship with the faculty advisor, it's a little bit separate, and it's because it touches to where they're what they're doing in their own programs back at school, and it gives them a different perspective, and they really value, I think, the opportunity to make a connection with another mentor, another faculty advisor that they can take back with them when they go, if they're not from the community, take back with them back to their schools, and have that as a resource, and know that we're investing the time in them, and we're giving your knowledge and sharing with them. They really value that.
Okay. Yeah, I had a chance to meet with them on Monday, and it was really good.
Oh, you did? Fantastic.
Yeah, we were able to meet and talk, and yeah, you're right. I think it will be a really good experience, and I'm hoping to make it worth their while and really be a good mentor to them.
Oh, that's great. Do we have any?
All right. So should we wrap it up and let people get on back to their lives, whatever? It's fascinating to think. Yeah. I've got child pickup coming up, but for other people, they're almost getting ready for bedtime. So.
Absolutely, we can let people hop off the line, but if any attendees have any questions about anything that was covered in the presentation that you think of 20 minutes from now or tomorrow, feel free to email them to PCLPinfo@nmsonline.org, or anyone from PCLP that you've received an email from so far, and we'll pass it along to Dr. Vega and I'm sorry, I'm just volunteering to answer those questions.
So yeah, my direct email is cpvega@uci.edu. Again, cpvega@uci.edu. So that I'm happy just to go with that, and if you feel free to reach out. And I like I said, we're not perfect, but we launched a huge effort with this model, and so far so good. So yeah, I look forward to spreading that gospel, because at the end of the day, that's going to result in more students becoming interested in primary care and more patients getting better care over time, and that's really what we're about.
Absolutely.
Okay. Well, thank you very much.
Thank you. Thank you, Chuck, for taking the time to do this, and everybody who participated in this call. So thank you.
Thank you.
All right. Bye-bye.
Have a good evening.
You too.